Here we see a damaged tooth with an abscess. Using a scalpel, make a flap incision. Care is taken to round the corners and incise on a bias at 45 degrees apical to the cortical bone when making an attached gingival flap. A full thickness flap may be made when indicated. A mucogingival flap is reflected and elevated using controlled peeling movements using a specially designed flap reflector and tissue elevator. The flap is reflected apical to the bony defect with a tissue retractor being held against solid bone, making sure the soft tissue is not being impinged upon. Next, an osteotomy is made at the apex with a handpiece. Approximately 3 millimeters of the apical root tip is resected perpendicular to the long axis of the root. The granulation tissue is removed using a small spoon and/or curette. Hemostasis may be achieved with basic ferric sulfate dabbed onto a well-placed telfa pad. Careful suctioning clears blood from the cortical plate to prevent it from entering the surgical site. Use an ultrasonic activated tip to prepare the apical 3 to 5 millimeters of the root end. Then use the Stropco dryer to dry the root preparation. Next, place the retrofilling material into the prepared cavity and condense with a microplugger. Place the retrofilling material a second time and condense with a microplugger. Remove excess material with a multi-fluted finishing burr with water coolant or wipe off the excess material with a wet cotton pellet. With tissue forceps, remove the telfa pad and bleeding within the bony crypt is initiated. The flap is gently repositioned with tissue forceps. Gentle pressure is applied to ensure close adaptation of the flap to the underlying bone. Then 2 tacking sutures are placed at the corners and then 1 at the center of the flap. Additional sutures are put in place as necessary,